Hello, folks. This is Steve. Welcome to Chapter 2, Week 2 of your phlebotomy course. Today we'll be going over Chapter 2, Quality Assurance and Legal Issues in Healthcare. So what are some of the objectives of what we want to do this week? Well, number one, we want to demonstrate the basic knowledge of terminology for national organizations, agencies, and regulations that support quality assurance in healthcare. Number two, we want to define quality and performance improvement measurements as they relate to phlebotomy, describe the components of a quality assurance program, and identify areas in phlebotomy subject to quality control, as well as quality improvement. And number three, demonstrate knowledge of the legal aspects associated with phlebotomy procedures by defining legal terminology and describing situations that may have legal ramifications. So as far as quality assurance in healthcare, there's always one question we should always be asking ourselves in healthcare, whether it's in emergency medicine, lab technician, radiology, nursing, anything is, what can we do better? How can we make things better? And to answer that question, we need to know a couple of these little terms. First of all is quality. Quality is the degree of excellence of something. You've all probably purchased something in the store, whether it was a high-end store like Macy's, where it was a very high-end quality, as opposed to your local 99-cent store where it was a low-end quality. Quality assurance are all the activities and programs in place to guarantee the excellence of patient care. All the procedures, protocols, all the activities and review, and that all go into making sure that patient has the best experience that they can be given. And so a continuous quality improvement program is just what it says there, a system put in place to improve the quality by continuously monitoring and analyzing all processes and identifying those in need of improvement. That's not necessarily to say to point fingers or to place blame on anybody. It's to find out what's not necessarily working so well and try to find out how we can fix it, or to find out what is working well and try to figure out how we can possibly make it better. So one of the biggest agencies that are involved in ensuring that all healthcare organizations have a continuous plan of quality improvement is called the Joint Commission. The Joint Commission is an independent, not-for-profit organization. It's the oldest and largest healthcare standard-setting body in the nation. It used to be called JACO, Joint Commission and Accreditation of Hospitals, but it's kind of branched out to accredit other agencies as well, and establishes standards for operations of hospitals and other health-related facilities and services such as urgent cares, accountable care organizations, clinical laboratories, and it seeks to improve healthcare for the public through evaluation and also through transparency, and it focuses on improving safety for patients and residents by making sure that these agencies adhere to their best guidelines and recommendations. So the Joint Commission put forth a survey analysis for evaluating risk, SAFER, implemented in 2017 to provide a visual representation of these survey results. So whenever Joint Commission does a site visit, and inspects and evaluates a healthcare facility, it puts all of its findings in writing and it publishes these findings. And these public findings are transparent for all the public to view. Helps healthcare organization prioritize and focus corrective actions. The SAFER matrix illustrates the likelihood of harm because of areas of non-compliance. And again, these are put forth transparently for the public to view. And the Office of Quality Monitoring evaluates and tracks complaints from not only patients, but also families and employees as well. The Joint Commission has what's called a Sentinel event policy. A Sentinel event is some type of lapse in protocol or some type of mistake that winds up leading to adverse patient outcome. So the Sentinel event policy in the Joint Commission does several things. It helps organizations identify safety issues and prevent them. If a sentinel event occurs, such as a patient falling out of bed or receiving the wrong medication, or even worse so, improper blood transfusion, the organization is required to do a few things. It's required to perform a thorough and credible root cause analysis to find out what was the cause of this sentinel event, develop an appropriate action plan, implement improvements to reduce the risk based on the research of their action plan, and monitor these improvements to determine if they are effective. And then they need to make these recommendations and these improvements known to the Joint Commission in a very measurable way. So the Joint Commission also has some goals. These are called National Patient Safety Goals, NPSGs. Part of the overall CQI requirement, Quality Control Improvement Requirements, overseen by safety panel of physicians, nurses, risk managers, and other healthcare professionals who all have a say in the matter. Patient safety goals for 2018 involve things such as identify patients correctly, which is very important. Anytime that you identify a patient, you want to ask them their name, their date of birth. You want to verify their patient ID number if they have one, and make sure that you match up the appropriate specimens, especially in the field of phlebotomy, where patient misidentification can prove to be disastrous. Improve staff communications. In any field, you can always improve communication between the speaker and the listener. And very importantly, prevent infection. We'll talk later on in some of your other courses about hospital-acquired infections and how these can be economically disastrous for the healthcare setting itself, not to mention for the patient as well. So the Clinical Laboratory Improvement Amendments Act of 1988 are a bunch of federal regulations passed by Congress and administered by the Centers of Medicare and Medicaid Services, or CMS. These regulations establish quality standards that apply to all facilities, including clinics, physicians' offices, laboratories, that test human specimens to provide information used to diagnose, prevent, or treat diseases and assess health status. These standards address quality assurance, quality control, proficiency testing, laboratory records, and personal qualifications as well. The College of American Pathologists is another agency that influences quality care through standards for the laboratory and phlebotomy. That is the College of American Pathologists, CAP. This national organization is an outgrowth of the American Society for Clinical Pathology. It's a not-for-profit organization for professionals in the field of laboratory medicine. Membership at CAP is exclusively for board-certified pathologists and pathologists in training. CAP offers proficiency testing and a continuous form of laboratory inspection by a team made up of pathologists and laboratory professionals. The CAP inspection and accreditation program does not compete with TJC, the Joint Commission accreditation for healthcare facilities, because CAP is designed for pathology laboratory services only. A CAP certified laboratory also meets Medicare and Medicaid standards because TJC grants reciprocity, or other words, mutual exchange of privileges to CAP in the areas of laboratory inspection. And then the National Accrediting Agency and regulatory agencies continued. The National Accrediting Agency for Clinical Laboratory Sciences is recognized by the U.S. Department of Education as an authority on quality in clinical laboratory education, which is what we're trying to provide for you here. Its mission is to be the premier international agency for accreditation and approval of educational programs in the clinical laboratory sciences and related health professions through the involvement of expert volunteers and its dedication of public service. The NAACLS accreditation process involves an external peer review of the program, including on-site evaluation to determine whether the program meets certain established educational standards. The NAACLS approval process for phlebotomy programs requires that the programs meets educational standards, otherwise known as competencies, which we'll refer to many times in this course, designed to improve student outcomes and maintain quality education. The International Organization for Standardization, or ISO, is an independent, non-governmental, international organization of about 162 national standards bodies from all over the world, whose members share knowledge and develop voluntary international standards that cover many industries, including healthcare. ISO standards are strategic tools that businesses can use to ensure that their products and services are of good quality and are safe and reliable. The QA, or quality assurance process, is a program that strives to guarantee quality service through scheduled reviews that looks at the appropriateness, the applicability, and timeliness of patient care. For instance, the laboratory's response to a comatose patient in the ER. Over the years, as healthcare has become more complex, there's been an increase in QA processes used by providers as they continually look for better ways to achieve their desired aims and outcomes. Processes that fail result in errors. Medical errors can be catastrophic. Therefore, it's important to adopt appropriate process improvement, or PI, techniques to identify problems or inadequacies and make changes that prevent errors. Some strategies and tools for improving quality and patient safety include failure models, effective analysis, FMEA, and Six Sigma, lean and root cause analysis, RCAs, and they're explained further in your textbook. One of the most important aspects of setting up a good QA identification and evaluation process is establishing quality indicators to monitor certain areas of patient care. For example, the lab must have quality indicators to monitor pre-analytical, analytical, and post-analytical processes. An indicator is defined as a measurement or value that provides information on what something like, such as the state of level or something, and what can be measured can be improved. Quality indicators are measures or values that provide information on the effectiveness or quality of processes. Quality indicators that measure adequacy, accuracy, timeliness, effectiveness of patient care, and customer satisfaction can be selected using available inpatient data. Indicators are designed to look for areas of care that tend to cause problems. For example, an indicator on the microbiology QA form in your textbook may show that blood culture contamination rate should not exceed 3%. That's a measurable standard goal, which every lab should probably take into account and strive to achieve. Threshold values must be established for all quality indicators. A threshold value is a level of acceptable practice beyond which quality patient care cannot be assured. Exceeding this level may trigger intensive evaluation to see if there's a problem that needs to be corrected. During the evaluation process, data are collected and organized. Data sources include such information as patient records, lab results, incident reports, patient satisfaction reports, which I have a personal issue with, and direct patient observation. A corrective action, preventative action plan, or CAPA plan, is established if the data identify a problem or opportunity for improvement. The action plan defines what will change and when that change is expected. The last step in the CAPA process is an effectiveness check in which steps are taken to verify that the problem has been corrected and has not recurred. Even when the problem appears to be corrected, monitoring and evaluation continue to ensure that this care is consistent and the quality improves. Quality assurance is traditionally looked at outcomes. Outcomes are in numbers only. For example, phlebotomy outcome measurement may give the number of times that a patient's specimens were redrawn because improper tube was used for collection. It's important to know how often this occurs, but it does not explain why it happened in the first place. To improve an outcome, the process must be reviewed. This entails following the process from start to finish. It means standardizing the way performance is measured and activities are evaluated. In the previous example, it would mean looking at what the requester did at the time he or she decided the test was needed, how it was ordered, and how the laboratory processed the request until the time the results were on the patient's chart and in the hands of the person who ordered them, namely the provider. To ensure that the same process is always followed, there must be checks and controls on quality all along the way. So areas of phlebotomy subject to quality assurance include patient preparation, specimen collection, and delta checks. Quality assurance and laboratory testing starts before the specimen is collected. To obtain a quality specimen, the patient must be prepared properly. Instructions on how to prepare a patient for testing can be found by checking the laboratory's test menu or catalog, which is usually electronically available on the web in most cases. Specimen collection procedures occur when the phlebotomist plays an important role in the QA process during the pre-examination phase of the testing process. Any step performed incorrectly in this phase can affect the quality of the specimen or of patient care. But the most important step is patient identification. All puncture devices must be appropriate for the lab that's being drawn. They must be sterile, one-time use only, and they must have appropriate expiration dates as well. The evacuated tubes need to be clean, standard, appropriately labeled. The technique has to be according to proper standards and techniques that you have been trained. And collection priorities need to be maintained as well. Which patient needs their bloods drawn first? Which ones can wait later on in the shift? And as you can see on this diagram here, we have a specimen tube with a barcode label and micro collection container with a barcode label, slide with a barcode label. But just a word of caution, there have been cases in which patient information on computer labels was incorrect because incorrect information was entered into the computer upon patient admission. Proper patient ID procedures can catch such errors, such as verifying name, date of birth, and other identifying information. So probably in just about any medical course you take, whether it be phlebotomy, EKG, if you take a nursing program, EMT, paramedic, physician assistant, or ultimately go on to medical school, you're going to hear the words over and over and over again. Documentation, documentation, documentation. And that involves what's going on in the patient's record. The patient's record is a chronologic documentation or list of the medical care given. The law requires that medical records be kept on hospital patients, does not require physicians in private practice to keep such records, but it would be foolhardy of them not to. Though most of them do so in the form of a clinical record. Every notation in the patient's medical or clinical record should be legible, which has traditionally been a problem with handwritten charts, factual, not subjective, and an objective account of the patient, past and present. The basic reasons for maintaining accurate, up-to-date medical records are as follows. 1. They provide an aid to the practice of medicine by documenting treatment and a plan for continued care. They provide an aid to communication between physician and others involved with present and future care for the patient. There may be many practitioners involved with the care of one single patient: primary care providers, cardiologists, orthopedics, respiratory therapists. Serves as a legal document that may be used in a court of law. It may be used by the patient to aid in the recoupment of money in a lawsuit, but it also may be used to protect you as the practitioner in the case of some possible frivolous lawsuit as well. It's also there to serve as a valuable tool for helping the hospital evaluate performance outcomes. The patient's records includes information such as history of examinations, medical testing, lab reports, prescriptions written, supplies used. These are all very informative for utilization review, monitoring process for appropriate cost-effective care. It can also help establish important statistical information to see about the appropriateness of treatment, how well things are going, how well things are not going. So test catalogs and reference manuals are searchable online menus or catalogs of QA documents made available to customers and blood collectors at all specimen collection sites. In an outpatient setting like a clinic or physician's office, there's the option to receive the instruction in the form of a printed reference manual. All these documents detail how to prepare the patient and any additional information needed to collect a high-quality sample. They typically list the test, the CPT code, which you might have learned about last week, type of specimen, amount needed, special handling requirements, such as does it need to be on ice, does it need to be dry, does it need to be transported rapidly, transport temperature, container type, and causes for specimen rejection. The procedure manual states the policies and procedures that apply to each test or practice performed in the laboratory. The procedure manual, or another QA document, must be made available to all employees of the laboratory for standardization purposes. Accrediting agencies such as CAP and TJC demand that this manual be reviewed and updated biannually or every 2 years. Some typical lists can be found in your textbook. OSHA, or the Occupational and Safety and Health Administration, mandates that a safety manual, which contains policies and procedures related to chemical, electrical, fire, and radiation safety, be present in every workplace. This basically contains information on how to handle all of these different types of emergencies. In today's healthcare environment, emerging infectious diseases and drug-resistant organisms such as C. diff and staph make managing all aspects of infection control more critical than ever. The Infection Prevention and Control Manual outlines policies, procedures for all employees in all areas of the healthcare organization and must comply with federal regulations and accreditation requirements. The manual addresses items such as hand hygiene, precautions to take when dealing with patients or handling specimens, and how to handle accidental contamination, including procedures to be implemented following exposure incidents, and also proper reporting procedures as well. Accreditation standards for agencies such as Joint Commission require the laboratory to have available all documentation on quality control checks in the phlebotomy areas. These may include temperature logs for refrigerators and freezers used for specimen storage, centrifuge maintenance records, heat block temperature logs, event report forms, and incident report forms. Your equipment check forms in hospitals and clinics, the facilities department use a computerized system to monitor freezers and refrigerators. Control checks on the centrifuge require documentation on the maintenance periodically. Just as the freezers and refrigerators is a responsibility of the facilities or biomedical services department to monitor centrifuges. These are the machines that spin the blood and separate the components. In smaller outpatient settings, often called patient service centers, the temperature logs and centrifuge information are sometimes kept on a paper log sheets and recorded daily by the phlebotomy supervisor. Internal reports, confidential incident and occurrence reports must be filled out when a problem occurs. These forms identify the problem, state the consequence, and describe the corrective action needed to prevent reoccurrence. All incident reports are to be completed when the occupational injury or exposure, such as an accidental needle stick, has occurred, or delayed medical condition has developed. No matter how minor the report, you must have a very low threshold for reporting, even if you think it's the most trivial of exposure. The long-term consequences can be catastrophic. Risk is defined as the chance of loss or injury and is inherent in the healthcare environment. Risk management is an internal process focused on identifying and minimizing situations that pose risk to patients and employees. Risk can be managed in one of two ways: controlling risk to avoid incidents and paying for occurrences after they have happened. Generic steps in risk management involved identification of the risk, treatment of the risk using policies and procedures already in place, education of employees and patients, and evaluation of what should be done in the future to prevent further occurrences. An individualized quality control plan is a quality control tool approach tailored to the laboratory's specific testing, population, and other unique factors. It allows labs to use whatever personal information tools are necessary to manage risk. Sexual harassment is a term we've all heard at some point in our lives, whether in our personal or professional or academic careers. For the purpose of our textbook, it's labeled as a form of sexual discrimination. It's a violation of Title VII of the Civil Rights Act. And if you look at the definition, it is persistent or offensive conduct related to a person's sex that negatively affects a reasonable person's job. There's a lot of gray area in the definitions of sexual harassment. That's why there are personal injury lawyers and judges and juries that view these cases case by case. It is not necessarily limited by gender or relationship. It's different than workplace harassment, otherwise called a hostile work environment. Sexual harassment can occur in many ways, but essentially it happens when there is unwelcome conduct of a sexual nature that is cruel or invasive, undermines morale, affects productivity, and can create a hostile work environment. Sexual harassment is not limited by gender, does not have to involve the opposite sex. The harasser is not always the victim's supervisor or superior. The person could be a coworker or even someone not employed in the workplace. Or it could be an independent contractor that works with the company. In the healthcare field, that person could even be a patient. An employee who experiences or witnesses harassment is responsible for reporting the occurrence to the appropriate person. Direct attempt at resolution, either verbally or in writing, is always encouraged. It needs to be made clear to the recipient, to the other person, that the action is unwelcome. And this has been a cause for many dismissals from the workplace, many dismissals from the academic settings, and many cases of lawsuits. So we can't talk about any type of medical profession without talking about some of the legal issues that occur in these professions. Because, like it or not, there are a lot of personal injury lawyers who would like to make some big bucks in claiming injury, whether it's justified or unjustified, and doesn't always have to be proven beyond the shadow of a doubt. So it's important to be familiar with some of these terms in medical legal training to help protect yourself in the event of a possible lawsuit, whether it's directed at you or you're named as a witness. So first thing to do is to understand what a tort is. The most common civil actions in healthcare are based on tort law. A tort is a wrongful act other than breach of contract committed against someone's person, property, reputation, or other legally protected right, for which the individual is entitled to damages awarded by the court. It's an act that is committed without a just cause and may be intentional or may be unintentional. It could include a number of different actions or a number of different situations. Some of the more common ones are assault and battery. We tend to have a little mixed identification of these terms. The term assault does not mean physical touching of somebody. It's an act or threat causing another to be in fear of immediate injury or battery, harmful touching. So it could be just somebody waving their hand in a threatening motion. It does not actually have to include physical contact. Battery is an intentional, harmful, or offensive touching of the use or the use of force on another person without consent or legal justification. So just a simple act of putting your arm around somebody's shoulder whom you don't know without inflicting any pain or damage could be legally considered battery for legal purposes. Fraud is a deceitful practice or false portrayal of facts either by words or by conduct, often done to obtain money or property. An example includes billing for services that have been provided, a big no-no. Invasion of privacy is the violation of one's right to be left alone. It can involve a physical intrusion or the unauthorized publishing or release of private information, or can also, in many of our cases, involve the unauthorized peeking into somebody's medical chart. Malpractice is a type of negligence committed by a professional. Training and experience of the accused individual is usually taken into consideration whether deciding whether the act resulted in injury and should be labeled negligence or malpractice. Negligence is failure to exercise due care. The level of care that a person of ordinary intelligence or good sense would exercise under given circumstances. Is a phlebotomist responsible for malpractice if they draw blood and they miss a vein and a bruise occurs in the left arm? No, not necessarily if they're providing all proper procedures. Is a phlebotomist providing malpractice if they started an IV line on a patient? Well, yes, because that's probably not within the phlebotomist's scope of care, scope of practice. So today, many practitioners, mostly high-end practitioners, physicians, physician assistants, nurse practitioners, carry malpractice insurance, and also healthcare agencies such as hospitals and urgent care centers and medical facilities also carry insurance. Malpractice insurance compensates the insured in the event of malpractice liability. Individual workers are not typically targets of lawsuits because of what's called respondeat superior or vicarious liability, both of which involve the deep pockets theory. In other words, let the one with the most money pay. They can, however, be named as co-defendants, in which case the employer's malpractice insurance may not cover them. It is important for healthcare personnel to examine the possibility of a civil suit being brought against them and to consider carrying malpractice insurance. The decision to purchase this insurance should be based on financial considerations as well as legal ones. From a legal point of view, it may be desirable to be covered by a separate professional liability policy because the employer may give his or her insurer the right to recover damages from the employee who's found to be negligent. Most malpractice insurance claims, however, do not cover what's called gross negligence. Healthcare personnel may be able to purchase malpractice insurance from their professional organizations. So, you ever hear the term, an ounce of prevention is always worth more than a pound of cure? Well, it just goes the same in preventing lawsuits. The best insurance against lawsuits is to take steps to avoid them. A good way to avoid lawsuits is to consistently follow your guidelines and always practice to the best of your ability within your scope of practice according to the standard of care. Acquire informed consent before collecting specimens. Let the patient know who you are, what the procedure is, what the risks, what the benefits are, getting their verbal or acknowledged consent if possible. Meticulously identifying patients and specimens as to not misidentify and miscollect a patient. Carefully monitor the patient after you've collected their specimen, making sure there is no excessive bleeding or any other signs of complication, accidental nerve damage from a misplaced needle. Always respect the patient's right to confidentiality. Don't go telling your coworker coming on shift, oh, guess what Mr. Jones told me, or guess what other disease they've got, or do you know what happened to them during your shift today? If it's not medically pertinent, leave it alone. And strictly adhere to your agency's accepted procedures and practices. Use proper safety containers and devices at all times. Do not recap needles. Make sure you discard your sharps immediately after using. Listen and respond appropriately to the patient's request. If the patient's telling you that they usually draw blood on their left arm, that their right arm is usually not good, maybe they've had a mastectomy and lymph node removal on their right arm, listen to them. Accurately and legibly record all patient info. Document incidents or occurrences, even if they seem trivial. Protect yourself. Document, document, document. Participate in continuing education to maintain proficiency in every level of medicine. There's always new updates, new procedures, new guidelines to be followed. Perform at the prevailing standard of care, and never perform a procedure that you're not trained to do, no matter what kind of pressure either a supervising nurse or physician or supervisor is putting on you. That is called gross negligence. It can not only land you out of your license, it could land you in a personal lawsuit, maybe even a criminal lawsuit as well. So just don't ever put yourself in that position. Make sure that every patient within possibility you obtain what's called informed consent. That requires voluntary and competent permission. So in other words, a person who's awake, alert, knows who they are, needs to be told who you are, first of all, what your role is, or what the procedure is, why the procedure is being done. I mean, you don't necessarily have to know the whole medical expertise, but say Dr. Jones wanted me to draw a blood sample to check your blood chemistry. Give the adequate information to the patient, and don't try to baffle them with your high level of medical knowledge, and always obtain their consent before the procedure. Of course, if the patient does not have the mental capacity to give you that consent, you do the best you can. But those are issues that need to be addressed when being given that order. And a little redundantly, expressed consent should be obtained whenever possible. It should be specific and cover all procedures to be performed. So, most likely in your case would be a blood draw. Verbal should be followed by entry in the patient's chart. So you want to obtain that patient's verbal consent, cover yourself as well and document in whatever form you have or whatever the patient's chart that that verbal consent was obtained as well. It gives you the best possible protection. Must be signed by the provider and the patient, must be witnessed by a third party. Obviously, it's an emergency situation. If you're doing blood draws when a patient is unconscious or crashing on the floor in the emergency room, you may not have that ability to obtain consent. That's understood. But whenever possible, make sure you cover all legal bases as often as you can. So what if your patient is unconscious, or what if they are unresponsive, or what if they don't have the mental capacity to make decisions for themselves? How can you get consent for that patient? In that case, you probably have obtained what's called implied consent. Sometimes implied consent is just what it says. The law acknowledges that that patient, if they were able to acknowledge you, if they were able to verbalize their wants, that they would agree to that procedure. Again, laws vary from state to state. Always check with your supervisor and your manager and your state guidelines as far as what is appropriate for implied consent and what is not. Most states have specific consent guidelines for the drawing of HIV tests. This goes back to some legal incidents and legislation that occurred in the 80s. Client must be advised of the test and its purpose. No patient can be tested for HIV without expressed consent. So the client must be told what the test is, how it will be used, the meaning of the test, and its limitations. For example, an HIV antibody test may not show a positive result if it's shortly within exposure. But that's usually information that the provider ordering the test should be explaining to the patient themselves. As far as consent for minors, minors cannot usually give consent for medical treatment unless it's an emergency situation. You'll usually need parental or guardian consent, and don't be afraid to ask for proof of guardianship as well. Don't just take it on face value. Personal Personnel who violate this rule are liable for assault and battery. And when it comes to assault and battery in minor patients versus adult patients, juries are probably less likely to be forgiving. And then also remember that patients always have a right to refuse treatment, refusal of consent. Patient has a constitutional right to refuse any medical procedure. Maybe based on religious beliefs, maybe based on personal beliefs. It may be just based on the fact that they're having a bad day or they're scared. Refusal usually must be verified in writing, and before refusing, patients should always be made aware of the risks and consequences of refusing that treatment. Now, that's usually not incumbent upon the phlebotomist or the technician to do. That's usually incumbent upon the provider to do. But if a patient is refusing the procedure that you've been ordered to do, you should let the appropriate person, whether it's the nurse, the manager, or the ordering physician, know as soon as possible. And so the reason we talk about medical legal issues is because we really want to do everything we can to avoid the litigation process. Litigation is a process used to settle legal disputes. Approximately 10% of malpractice lawsuits go to court. The rest are settled out of court, which can happen at any time to the final court decision. Malpractice litigation involves the following 4 phases. Phase 1 begins when an alleged patient incident occurs or the patient becomes aware of a prior possible injury. Phase 2 is a little more complicated. It begins when the injured party or family member consults an attorney. The attorney requests, obtains, and reviews copies of the medical records involved and decides whether to take the case. If the attorney thinks the malpractice has occurred and takes the case, an attempt to negotiate a settlement is made. If the case is not resolved by negotiation, a complaint is filed by the patient's attorney. Once a complaint is filed, the injured party becomes the plaintiff, and the person against whom the complaint is filed becomes the defendant. Both sides now must conduct a formal discovery, or what's a process in which both sides exchange information about witnesses and evidence that will be presented in trial. Discovery typically involves depositions and submitting written questions called interrogatories, which must be answered by the other party in writing. Giving a deposition is a process in which one party questions another under oath while a court reporter records every word. The plaintiff, the defendant, and expert witnesses for both sides may give depositions. Expert witnesses are persons who are asked to review medical records and give their opinions on whether the standard of care was met. A person who lies under oath while giving a deposition can be charged with perjury, which is a federal crime. Then at phase 3 is the trial phase, which we like to try to avoid. The process designed to settle a dispute before a jury. Both sides present their versions of the facts, and the jury determines which version appears to be correct. If the jury decides in the plaintiff's favor, damages may be awarded. At this point, the lawsuit may proceed to phase 4. Phase 4 begins with an appeal of the jury's decision. Although either side has the right to an appeal, the losing party is usually the one to choose this option. Usually, like I said, only about 10% of cases usually make it to trial. When it taken into account all the court costs of defense and lawyers and depositions and time away from work, most agencies will usually agree, or most malpractice insurance will agree to settle upon an agreed amount rather than take a chance on losing all those costs involved with going to the trial process. However, once a settlement is made, then malpractice insurances can make the decision whether they want to keep that client in good faith or not. So it's always best to try to avoid being involved in a lawsuit to begin with. All right, so let's just go over some of the competencies that should have been met in this chapter. So some of our competencies, and some of our objectives. So we want to describe the legal and ethical importance of proper patient sample identification. We know that the mistakes in that can be catastrophic. Describe quality assurance in the collection of blood specimen, making sure they're properly labeled. Identify policies and procedures used in the clinical laboratory to assure quality and obtaining of blood specimens. Make sure the centrifuge is working properly. Make sure the refrigeration is working properly. Define and use medical legal terms and discuss policies and protocol designed to avoid medical legal problems. And hopefully that's it. If there's any questions, please feel free to bring them to class or post them in the open discussion forum in Blackboard. Thank you very much.